Hey guys, welcome to Nurse Howie, and I'm here to discuss a little bit about schizophrenia. So schizophrenia is schizophrein for Greek for split, and phren is for mind. And it's important to talk about because it takes a little bit of finesse to diagnose and a lot of resources to treat schizophrenia. One of my preceptors said that if there's something that you need to know, it's schizophrenia, depression, and bipolar disorders. Those are the big three, she said. So we start into this one. What do you think about this office space, huh? Trying something new a little bit. Anyway, so again, hi, I'm Nurse Howie, and I'm a psych mental health nurse practitioner, student, or psych NP student for short. I'm trying my best in school, getting good grades, and doing fulfilling work as an RN full-time, but I want to expand my knowledge further, so I'm doing these video notes of what I learned. So thanks for tuning in. Schizophrenia is probably the most subtle of the big three psych disorders. Why? Because it has both positive and negative symptoms as well as specific criteria for diagnosing. What does that mean exactly? Well, before we discuss that, let's put a little bit of schizophrenia into context. As you know, I'm currently a bachelor's prepared registered cardiac nurse, but I've worked in psych for quite a few years also. And I remember quite a few inpatients in our hospital psych department that stood out to me. There were no individuals that I can name, but they did have certain characteristics. For one story, this particular client would always be escorted back into our psych department after being brought in by the police. He or she would be found somewhere on a city bridge at night trying to make it to the center. Now, the highest section of that bridge is where people try to commit suicide. They jump off. But this patient would walk a long way. Many patients that are trying to commit suicide have to walk a long way after taking a lengthy bus ride and try to make it to the bridge. So it's a lot of intent to try to get there. But the police would see the patient and take them in right away before he or she did anything. But what was the patient trying to do? Obviously, he or she is trying to commit suicide. So many bridges are suicide bridges in major cities. For example, Golden Gate Bridge is the number one. There's one in Washington State, and the third one is Coronado Bridge in San Diego, and the fourth, I think it's I'm not sure where the fourth one is. Somewhere in Seattle, I think. Anyway, just to be clear, there were only a few patients that had suicidal ideation, which is the idea of wanting to commit suicide but not yet committing one, even though they're close to doing it. Most schizophrenic patients, the rate of suicide decreases immensely after the first 5 years of schizophrenic signs and symptoms. You can check out my links to the references down in the comments below. And it's what we call early schizophrenia. We'll talk more about this later in the video. But now let's talk about the DSM criteria 1. Like with any good diagnostician, it is important that you diagnose your patient properly. These diagnoses can follow your patients for life. It can affect what medications they get, what treatments they seek, and even their medical insurance. Not to mention their family life, social, and occupational relationships. These are things that many of us take for granted, but are largely important to our health and well-being. It's part of what we call quality of life. It's just as important, if not more so, than length of life, at least in my professional and medical opinion. The Diagnostic and the Statistical Manual of Mental Disorders 5, the latest version, is the 5th incarnation of a manual that was put together by a panel of experts seeking to streamline mental health classification for psych professionals around the world. This latest was supposed to be the last one, but it has had its share of criticism by those that appreciate the previous version. So they still use aspects of the 4th edition as well as aspects of the 5th. They pick and choose. But that's not today's topic. Today, we are supposed to be talking about schizophrenia first, so we must know how to diagnose it. These are the 5 main criteria. So I just think about it through my hand. So there's 5 major criteria that your patient has to have in order for you to be able to diagnose them as schizophrenic. 1, they have to have delusions. 2, hallucinations. 3, disorganized speech, not behavior, but speech. And 4, grossly disorganized or catatonic behavior. Finally, 5, and it's negative symptoms, having negative schizophrenic symptoms. It's actually one of the more subtle yet very important aspects of schizophrenia diagnosing. Think of these as a new symptom for each finger, so delusions, hallucinations, disorganized speech, disorganized behavior, or catatonia, and negative symptoms. So delusions, hallucinations, disorganized speech, behavior, disorganized or catatonic, and negative symptoms. So I'm going to recommend a few videos to talk about these a little bit more, because I don't want to reiterate what these videos have done a great job doing and saying. So I'm going to put them here in the cards area, or you can check out the links down below in the comment section if you want to go check them out. And these are good introductory schizophrenia diagnosing descriptions of the criteria for diagnosing schizophrenia. I'm sorry. Let me just say that again. May need more coffee. These videos do a good job of describing the criteria that makes up how to diagnose a schizophrenic patient. But let's go back to what's going on with some of the other schizophrenic patients that I've seen. Back to story time. So what's actually more common, at least in my experience, are schizophrenic patients that are hearing a lot of audio hallucinations. They self-respond to something that nobody else can hear. So they may also have some paranoia and disinterest in many things. If you've seen the videos that I mentioned, they'll talk about that quite thoroughly. So oftentimes I can see them based on their usually expressionless face. So that's how I can tell if I come into my unit, my psych unit, and there are a couple of patients that I'm not familiar with, and they'll say, oh, one of them has schizophrenia. Most of the time I can see who is schizophrenic after I'm watching the milieu, the general area, for about a minute or two. But schizophrenia is a manageable disease, not disease. Let me clarify. It's a disorder, not a disease. It's a manageable disorder, but it does take a lot of resources. It burns out a lot of the resources for family and friends, because the schizophrenic patient doesn't know any better. He or she just might not respond to you very well anymore because he or she is disinterested or have a hard time trying to gather the thoughts into a coherent conversation, or they're just having a hard time managing their lives because they have severe deficit of level of functioning. So we'll talk about that as well. So now that you've seen the criteria from the YouTube videos and from me talking about them, the 5, what were they again? Delusions, hallucination, disorganized speech, disorganized behavior, and negative symptoms. So let's dive in a little bit deeper for the other criteria. Now those 5 symptoms in my one hand are for criteria A, but what about B through F? So criteria B, you ready? Okay, so criteria B is a significant decrease of the level of functioning of the client. So this can include many things, but I relate it, if anybody else can specify even better than I can. If I'm off the mark, let me know. But how I relate it is if the patient is not functioning in their day-to-day, everyday lives. This can be just being a family at home, or trying to work a job that they previously were good at, or just a job that just pays the bills. They can't function in a normal, daily recommended way. So criteria B says that if there's a significant decrease in the level of functioning, which is, to me, having interaction with their family and friends, or interacting with their coworkers, to live a normal everyday life. Pardon me for using the normal, because there really isn't a normal, but just what I mean is just that more of a mundane life that you and I can usually do on an everyday, day-to-day basis. Do you get it? Okay. So that's criteria B, but from what I've studied, it doesn't really describe exactly how much is considered a significant decrease. Now, if the patient can't get through one day without having a disturbance in their thought process, where they have a delusion, hallucinations, or disorganized speech or behavior, then that's significant to me because it's significant to the patient. So that's how I look at it right now. Moving on to criteria C, it is to indicate a longer timeline of a 6 months duration of symptoms. It's not necessarily chronologically, but intermittently spanning the length of time for these symptoms. The symptoms of a criteria A should last at least over 1 month, but the repeated occurrences of each symptom should be at around at least 6 months or more. So this is another reiteration of the criteria A, but with a timeline guiding the length of criteria A. Criteria D is used to rule out other mental disorders that usually follow schizophrenia or hide it. Schizoaffective disorder is a subtype of schizophrenia, and this will be discussed in different videos. These are different subtypes. Also, they're more pertinent to this DSM-IV. And bipolar disorder, though, is also different from schizophrenia, but they share many signs and symptoms in patient behavior, especially with regard to psychosis, which is another great indicator of determining whether or not it is actually schizophrenia or something else. It's important to understand as a clinician that signs and symptoms of schizophrenia, listen to this, are not pathognomic. I don't know if I said that word right, but it's a very good word to describe that. The symptoms that describe and allow you to diagnose schizophrenia is not exclusive just to schizophrenia. It can be caused by major depression or bipolar disorders, mania or depression, or different mood disorders or swings, or it can be caused by a substance abuse disorders such as alcoholism or alcohol-induced disorders. So you really have to be able to push those other possibilities out in order to concretely term your patient schizophrenic. All right, so depression often underlies a lot of schizophrenic patients' lives, but they're not necessarily schizophrenic patients, okay? So moving on, criteria E. It is included in all of DSM-V's mental health disorders, and its purpose is to just remind you that you must rule out substance abuse disorders. I mentioned that earlier in criteria D. These can sometimes trick you into thinking that the client's psychosis is a real disorder, when really he or she is just suffering from an acute mental status change from illicit substances or excessive or inappropriate alcohol use. So make sure your patient's not drunk, make sure your patient's not high, make sure your patient's not suffering from any other disorders that cause them to be delirious. Just really take out delirium in that aspect. That's why the time value of criteria A and criteria A and C is very important, because they want you to prove that these symptoms have been going on for a long time. It's not a simple, quick, delirium is not simple, but it's not delirium. It's not short-term, it's long-term. Many of the schizophrenic patients have their signs and symptoms usually generate after adolescence, a little bit earlier for men than women, but there's also such a thing as the diathesis stress theory or diathesis stress model that also incorporate not just genetics, but outside external influences that determine whether or not your client or you develop schizophrenic symptoms earlier rather than later, and how severe it is. Okay? Finally, last one, criteria F determines that schizophrenic patients that are in the autism spectrum disorder or have a communication disorder from childhood are not mistaken for having schizophrenia. This is just a way to rule out. So for all those PEDS clients or PEDS mental health nurse practitioners or PEDS psychiatrists, they want you to be able to discern that your young patient is not schizophrenic and they're dealing with something else now. Those who work psych know that a psych pediatric client or psych adolescent client are not the same as a psych adult client. They both have extremely different diagnoses and different treatment programs. And so there are many specialists that handle just pediatric psych or just adult psych. They rarely mix the two because they're both different, almost completely different worlds, you know. For example, a lot of the kids, that are in ped psych can be really early suicidal, can still get depression just like adults do, but they're also mostly focused on ADD, ADHD, oppositional defiant disorder, stuff like that, stuff that also involves a lot of parenting and schooling, whereas adult psychiatric disorders more focus on symptoms and criteria that occur later in life. So, to close it all off, is that that's it for our intermediate mental health lesson, and I hope you learned something today. It's good for me to review all this stuff, and I want to learn just as much as anybody else, and I want to be truly called a professional, so I really want to continue to dig into these symptoms and lessons and whatnot, and I'm going to try to find more references for you so I can back up my claim without having to just say it. But I do hope that you learned something, and I hope that you interact with me and tell me if you find anything that new, or if you think that I said something wrong, or if there's something that you think I can improve on. But if you did learn something today, please let me know. I'd really be happy to hear about it. But let me know what you think too, and if there's something I could have done better, if I made a mistake, let me know. And if you like it, please hit the thumbs up button and hit the subscribe button and the bell to make sure that you receive notification of my next videos, okay? Again, please subscribe, like Nurse Howie, hit the bell, get the notification, and I hope that you're always learning, because I am. So I hope you watch my videos in the future and learn with me, okay? All right, thanks again. Nurse Howie, out.